Hi, I'm Kristen Coverly, ABMP's Manager of Professional Development. I've developed the ABMP BizFit Workshop Series and on an ongoing basis create resources and education to help you market and manage your practice. And I absolutely love it. Today, I'm so happy to be here to introduce our next speaker in the ABMP Head and Neck Summit, Clint Chandler. I was so fortunate to be one of Clint's students as I was going through my core program and then was able to teach side by side with him as a faculty member for 7 years. As an educator, he is incredibly knowledgeable and kind, and I think you're absolutely going to love learning with and from him today. I'm so pleased to introduce his next upcoming webinar, which is Somatic Dysfunction as a Contributing Factor in Head and Neck Pain with Clint Chandler. Clint is a recognized leader in the field and won the Jerome Perlinsky National Teacher of the Year Award in 2002. He's developed and implemented core and advanced training and curriculum at some of America's leading educational institutions, programs, and publishers. His extensive professional career spans over 26 years in both clinical practice and teaching massage and manual therapies. Today, Clint will share the basics of somatic dysfunction and demonstrate passive positional release techniques to help clients with head and neck pain. I hope you absolutely enjoy this session and are learning a lot at the ABMP Head and Neck Summit.
The topic and concept of somatic dysfunction is not a familiar or widely used term in the massage therapy community. However, it has been a common concept and term used within the osteopathic community for some time now. The concept of somatic dysfunction points to the important role of the muscle spindles as a contributing factor in pain and loss of function. Mechanically releasing and manipulating the various soft tissues of the head and neck may, in some cases, only provide temporary relief or benefit. Therefore, we may need to incorporate hands-on methods that influence or reset the nervous system, like passive positional release. By consciously thinking about all the body's structures and systems, then we can approach our work with the intention of influencing each system, layer by layer, starting with the most superficial layer and then going deeper. This approach should allow the body the opportunity to receive and appreciate and respond to the work, and it provides us with a sequential order of working with each individual client situation, all the while maintaining the primary intention of working to restore normal length, tone, and blood flow, reducing fascial restrictions, and resetting proprioceptors. Hello, I'm Clint Chandler, and I'm happy to be here today as one of the many presenters that are part of ABMP's Head and Neck Pain Summit. If you are interested in my work and want to learn more, please check out my 3 mobile apps called MyoFinder, MyoQuiz on iTunes, and the Key Terms Palpation and Movement on iTunes and Google Play. For more information, visit my website at www.bionexusllc.com. My goal today is to offer a different framework for approaching the treatment of head and neck pain. First, we'll talk about somatic dysfunction and explore the anatomical structures that might cause tenderness and pain in the head and neck region. At the end of this session, I will demonstrate some effective palpation and treatment techniques for clients with head and neck pain. So let's get started. In osteopathic medicine, osteopathy, somatic dysfunction is defined as the impaired or altered function of related components of the somatic bodywork system, the skeletal and arthroidal and myofascial structures and their related vascular, lymphatic, and neural elements. Somatic dysfunction implies that all the structures, joints, bones, ligaments, capsules and cartilage, and tissue, fascia, muscles, tendons, nerves, blood vessels, and lymph vessels of a given area can play a significant role in the production of pain and loss of function when acutely or chronically strained. For example, a client seated in a car at a stoplight has their head placed in a forward position, watching and waiting for the light to change. All of a sudden, out of nowhere, they are caught off guard, element of surprise, by the rear end impact of a car coming up from behind them. Prior to the time of impact, the neck flexors are short of their resting length, and the muscle spindles in these muscles would be reporting little to no activity with no change of length taking place. The neck extensors would be stretched and firing rapidly in order to hold the head upright, gazing at the light. The sudden impact from the rear-end collision causes the head and neck to be snapped up and back into hyperextension. Muscles like the sternocleidomastoid would be suddenly stretched, triggering a myotactic stretch reflex or muscle contraction. This contraction causes an instant inhibition of the antagonist, or in this case, the extensors. The flexors and extensors' effort to stabilize and protect the head and neck from these acceleration and deceleration forces result in a scrambled message and inappropriate proprioceptive reporting in the central nervous system. The signs and symptoms associated with somatic dysfunction can be represented by the mnemonic STAR. Sensitivity can best be described as the client's subjective complaint of pain or discomfort, as well as the loss of movement of the head and neck region. The client reports sensitivity based on his or her experience of the symptom. Sensitivity can also be an objective observation made by the therapist when a tender point is palpated and the client reacts and reports tenderness or increased sensitivity. Increased sensitivity to touch, temperature changes, and pressure are common signs of somatic dysfunction. Tissue texture quality. There are several descriptors of tissue quality, and they are the foundation of palpable findings that often direct the treatment focus. They include edema, which means increased fluid or swelling; fibrosis, which means a thickening and scarring; atrophy, which means loss of muscle mass; rigidity, which means stiff, hard, and not flexible; hypertonicity, which means increased muscle tone. Tissue texture quality changes can be a result of changes in blood flow, inflammation, and increased neural activity within a given region. Asymmetry is best observed from a visual standpoint. A person's postural alignment may be misaligned or asymmetrical. For example, the head and neck may be in a forward-leaning position. From this position, the muscle mass of the neck may be different sizes, or their anatomical parts may not be in the same location or same size. Asymmetry of the body structures can lead to changes within the fascia, muscles, tendons, bones, joints, blood vessels, lymphatic vessels, and nerves, causing pain and loss of function. Restriction is usually reported by the client as the inability to perform some task, activity, or specific movement pattern. Often it is unclear why the movement pattern is restricted, but most clients report some change in muscular tension or a pinching sensation associated with a specific joint. Restriction involves both changes in quality and quantity of movement. Now that we've looked in more depth at the signs and symptoms associated with somatic dysfunction, let's review some specific anatomical structures key in our discussions today. The complex nature of the head and neck anatomy and the close proximity in which these tissues and systems exist can make this region somewhat intimidating for the novice therapist. The head and neck are independent and unique structures, yet they are interconnected structurally and functionally. They are reliant upon each other for cooperative and synergistic functions of cognition, vision, hearing, and speaking. They are in constant communication with each other biochemically and neurologically, as the central nervous system talks to the peripheral nerves and vice versa. The cervical spine supports the head on one end and is anchored by the immovable thoracic spine on the other end. Because of the cervical facet joints are arranged at 45 degrees from vertical, the cervical spine allows for the greatest range of motion of the entire spinal column. There are 7 distinct vertebrae which form the cervical spine. The atlas, or C1, is a ring-shaped bone that has no vertebral body or spinous process. Its transverse processes are wider and stronger than other cervical vertebrae. The axis, or C2, has a bony projection arising from the anterior portion called the odontoid process, or DINS, which articulates with C1 to form the atlantoaxial joint. C3 through C6 has a common characteristic, which is a bifurcated spinous process. C7, or the vertebra prominens, which is the most prominent of the cervical spine and is also referred to as the transitional vertebra because it takes on some of the characteristics of the thoracic vertebra, which is a larger body and change of orientation of the spinous process and the facet joints. The cervical vertebrae share some common characteristics. They have one transverse foramen on each side. They have small vertebral bodies. Their facet orientation is horizontal 45 degrees from vertical. They have large vertebral canals, which forms the opening for the brainstem. They are wider transversely than they are anteriorly. They are wider posteriorly than they are from their height. The gutters for the nerves run anterior and lateral. They also have uncovertebral joints or Luschke's joints from C3 through C7. Our cervical spine is highly functional when it is functioning properly. Our head is supported and stable. The articulating facets allow precise movements in 3 planes. Our spinal cord, vertebral artery, vertebral vein, and sympathetic nerves are protected. We can do things like look over our shoulder to back up the car. At birth, the vertebral column is one long posterior convex C curve. When a young infant begins to lift their head up, the muscles develop to hold the head upright, to gaze and take in the environment around them. This will eventually allow the head to sit on top of the cervical spine. The effects of gravity from the weight of the skull, muscular development, and the formation of the intervertebral disc all help to form the lordotic curve of the cervical region. A functional cervical spine has the proper degree of cervical lordosis. You'll remember that cervical lordosis is the curve in the cervical spine that helps to stabilize the head and spine. It assists in resisting axial compression from the forces of gravity. When it is functioning properly, it is a flexible, protective column that is highly movable, balanced, and capable of environmental adaptation. However, when the curve straightens out, becomes too deep, or faces in the wrong direction, it can be a problem. This changes the weight-bearing forces onto the facet joints and away from the intervertebral disc, which are the primary shock absorbers of the spine. Over time, these forces and increased friction can cause breakdown of the joint surfaces of the facets and intervertebral joints. This can lead to degenerative changes, which can cause more pain and loss of function. For the purpose of today's presentation, I've selected one jaw muscle, the masseter, and one anterior cervical muscle, the sternocleidomastoid, and one posterior cervical muscle, the splenius capitis. The rationale behind the selection of these 3 muscles is based upon the fact that the masseter and SCM are very responsive to passive positional release, and that both muscles are often avoided or not treated, whereas the splenius capitis is often overtreated and can become fibrotic, sometimes responding poorly to passive positional release, requiring more aggressive methods such as transverse friction. Let's take a look at the 3 muscles. First, we'll take a look at the masseter. The attachment sites or the origin of this muscle is the zygomatic arch. The insertion is the angle and ramus of the mandible. This muscle is responsible for elevating the jaw, as in chewing food or gum, and it also protrudes the jaw. It's important to note that this muscle can refer pain deep into the ear and into the temporomandibular joint. Let's take a look at the masseter muscle on the skeleton. The masseter has an origin on the zygomatic arch. This muscle runs down and has an insertion point on the angle and ramus of the mandible. To help us identify this muscle, we'll perform one of its primary actions, which is to elevate the jaw or to clench the teeth. We can see the muscle belly of the masseter located here. To palpate this muscle, we'll use a flat palpation technique to strum across the muscle belly as we trace it all the way down to the angle and ramus of the mandible. There's a superficial belly and a deep belly. The deep belly is located here, and some of it is superficial and easy to palpate. We'll trace it all the way down to its insertion point on the mandible. The next muscle is the sternocleidomastoid. The attachment sites of this muscle, the origin is on the anterior aspect of the manubrium and the medial clavicle. So there's two heads. The insertion point is at the mastoid process of the temporal bone and the lateral aspect of the superior nuchal line of the occiput. This muscle's actions are to bilaterally flex the neck, and it pulls the head forward. It rotates the head to the opposite side, and it laterally flexes the neck. It may participate in inhalation if the head is not forward. It's important to note that this muscle is prone to shortening and hyperactivation from forward head posture. Now let's take a look at the sternocleidomastoid on the skeleton. The sternocleidomastoid has an origin on the superior anterior aspect of the manubrium, that's the superficial belly, and the medial clavicle, that's the deep belly. This muscle runs up and has an insertion point on the mastoid process of the temporal bone, located here, and the lateral aspect of the superior nuchal line of the occiput. To help us identify this muscle, we'll perform two of its primary actions, which is rotation to the opposite side and flexion of the neck and head. We can see the distinct borders of the deep belly and the superficial belly located here, and the deep tendon or muscle attachment here. To palpate this muscle, we'll flex the head and neck and rotate it to the same side. Using a pincer palpation technique, we'll reach around the superficial muscle belly and trace it down towards the origin. We'll rotate the hand around to the other side to pick up the tenos attachment on the manubrium. We'll come back up, rotate the head just a little bit more to the same side so that we can pick up the deep belly, trace it down towards its origin. We'll switch the palpation technique as we trace the tendon down onto the medial clavicle. The splenius capitis. The attachment sites for this muscle, its origin is the lower portion of the ligamentum nuchae, the spinous processes of C7 through T4. It inserts onto the mastoid process on the lateral superior nuchal line. This muscle is responsible for bilateral extension of the head and neck, unilateral rotation and lateral flexion to the same side. It's important to note that this muscle, when in spasm, causes the neck to be stiff and difficulty in rotating the head. Now let's take a look at the splenius capitis on the skeleton. The splenius capitis has an origin that runs along the ligamentum nuchae, located here, C7, T1, T2, T3, and T4. This muscle runs up and has an insertion on the superior nuchal line of the occiput, located here, and on the mastoid process of the temporal bone. To help us identify this muscle, we'll perform two of its primary actions, which is extension of the head and neck and rotation to the same side. To palpate this muscle, we use a flat palpation technique. We'll locate the spinous processes of the upper thoracic vertebra. We'll strum across the muscle belly. If we're not sure if we're on it, we can ask the client to activate the muscle again. We'll come back down. These are the spinous processes. Just lateral to that, we'll trace the muscle belly up to its attachment site on the lateral aspect of the superior nuchal line of the occiput and the mastoid process. This brief anatomical review covers a small subset of some of the important structures, muscles, and tissues that make up the head and neck region. Most educational training programs do a pretty good job of creating awareness around the presence of trigger points as a cause of pain and dysfunction within the various soft tissues. The concept of somatic dysfunction and its associated tender points is rarely covered or explained in entry-level educational programs. The advanced therapist who is outcome or result-oriented should become well-versed in understanding the distinct differences between these two types of points and their respective treatment approaches. There can be some overlap of treatment approaches. However, if you find that if you're not being effective, it might be better to use the method designed for the specific type of point. Okay, let's define the two different types of points. A tender point is small zones of tense, tender, edematous muscle and fascial tissue that are at least 4 times more tender than normal tissue. A trigger point is hyperirritable spots in fascia surrounding skeletal muscle. They are associated with palpable nodules in top bands of muscle fibers. Let's look at some of the physical characteristics between these 2 points. A tender point is tender, tense, edematous, the size of the fingertip. It has no twitch sign, no referral pattern, and no autonomic phenomena associated with it. Whereas a trigger point is oftentimes painful, has a top band or a pea-shaped nodule. It varies in size. It has a distinct twitch sign, or it can have. It has a distinct referral pattern and oftentimes autonomic phenomena associated with it. The symptoms of these 2 points are pain and loss of function. The common signs and symptoms associated with these 2 types of points have caused a lot of confusion for both the layperson and for many healthcare professionals. However, a closer look illustrates some very distinct differences between these 2 types of points. Many healthcare practitioners have also used these terms interchangeably, adding to the confusion. A great example of this was the tender point digital pressure test that served as the old diagnostic criteria for fibromyalgia. Some medical professionals called them tender points and some called them trigger points. The location of these points, a tender point, is located in the superficial or deep layers of the fascia, muscles, ligaments, bones, joints, and they're often located in the antagonist muscles. Whereas a trigger point is found in the muscle belly and attachment sites. They can also be found in the referral zones. Neurological involvement of these 2 points. A tender point is caused by inappropriate proprioceptive activity of the muscle spindle that we gave the example of the whiplash injury earlier. A trigger point is caused by motor end plate dysfunction or an energy crisis. Restriction. The tender point causes decreased movement, loss of range of motion, and then therefore joint dysfunction. Trigger points can also cause decreased range of motion, but they also can cause muscle weakness. So the treatment methods for tender points are strain counterstrain, passive position release, and it's important to note that tender points do not respond to injection therapies or spray and stretch methods. Trigger points can respond to a variety of manual methods. They also respond to injection therapies and spray and stretch therapies. We have highlighted the distinct differences between tender points and trigger points, which should help guide your treatment selection. The most critical thing to understand is that passive position release is not directed at resolving tissue damage. It is directed at the aberrant neuromuscular reflexes that is typically found in the antagonist muscles. Passive position release is a gentle yet subtle approach that can be utilized in a wide spectrum of acute through chronic sprain situations. This technique is considered an indirect technique because it typically focuses on the antagonist muscles, which is not where the client is complaining of pain, and it works in the direction of ease and not into bind. The treatment goals and benefits associated with passive positional release include decreased central facilitation, reduction of tension of the fascial collagenous fibers, improved blood flow to the local tissue, restoration of normal range of motion, decreased proprioceptive hyperactivity, and the reduction of somatic or musculoskeletal dysfunction. Okay, the sequence of application of passive position release goes like this. Number 1, locate the tender point by palpating the tissue. Number 2, passively move the head neck into a comfortable position. Number 3, maintain the location on the tender point, but take the pressure off of the tissue. Hold the head and neck in the comfortable position for 90 seconds. After 90 seconds, slowly return the head and neck to a neutral position. At that time, you'll elicit the client's feedback to assess changes in the tender point. Effective treatment is considered 70% reduction in the tenderness of the point. Here are some notes and observations to make. Apply pressure that elicits tenderness, not pain. Perform passive movements slowly and continuously communicate with the client to avoid missing the correct position where the tenderness is turned off. You must be able to hold a particular position for 90 seconds. So check that your body mechanics are comfortable and correct. Slowly return the head and neck to a neutral position to avoid activation of the muscle spindle cell reflex. When multiple tender points are found in an area, treat the most severe point first. Anterior tender points usually respond to flexion. Posterior tender points usually respond to extension. Now we have identified the specific goals and benefits of passive position release. We have provided a detailed outline of the sequential order of the actual application of this approach, and we have outlined specific observations that should be made during the application of this method. Now let's see this approach in action. Now let's take a look at passive position release directed towards the masseter muscle. And I just want to point out that all of these techniques are done prior to using lubricant or lotion. So remember that the masseter is located along it attaches right along the zygomatic bone located here, runs down to the angle and the ramus of the mandible. So I'm just going to use a strumming palpation technique to locate. Can you just clench your jaw for me and relax? I'm looking for a tender point in this muscle belly. Is that tender right there?
No.
How about right there?
Right there.
Okay. Now what I'm going to do is use the other hand on the other side of the jaw. Just let me open your jaw, and I'm going to take it across. Does that feel okay?
Mm-hmm.
You still feel the tenderness?
Yeah, not as much.
Did it turn it all the way off?
Almost all the way off, yeah.
How about there?
That's good.
Okay. We'll hold this position for 90 seconds. So the key things in doing this technique are to first locate the tender point, slowly have the client relax their jaw as you open it, and then you're going to deviate it to the same side as the tender point is located. 90 seconds is a long time, but that's the time it takes to reset the muscle spindle cell. After the 90 seconds has passed, we want to go out the same way that we came in. We're going to let the jaw come back to neutral and then let it close down. And then we'll check back in with the client. How does that point feel now?
It's not tender anymore.
So that's considered an effective treatment of that particular somatic dysfunction within the masseter muscle. Now let's move on to the sternocleidomastoid muscle. This muscle has attachment sites, as we said earlier, on the manubrium of the sternum, the medial clavicle, the mastoid process located here, and the superior nuchal line. To palpate this muscle, we want to flex and rotate the head to the same side. We're going to use a pincer palpation technique to encircle this muscle. We'll start at the top. 1. Let me know the most tender point, okay?
Okay.
1, 2, 3, and 4.
3.
Number 3. Right there. Do you feel it anywhere else or just right where I'm at?
I feel it most right there.
Okay. Now what we're going to do is flex the head and neck. Did that turn it off right there?
Yep.
And we're going to hold this position once again for 90 seconds. I'm resting my elbow on my leg to help support the head. When you find the point of ease, oftentimes the point becomes mobile, meaning it moves around. You can let off of the point, but I like to maintain the pressure so I don't lose the exact location. Remember, the key thing is slowly move into the position of comfort and then slowly return to a position of the neutral position from where you started. We'll slowly return the head and neck down, and we'll check back in with the client. How does that point feel?
That feels great.
And how about the rest of the muscle? Did it change anything in the rest of the muscle?
Yeah, most of the muscle feels a lot less tender.
So in this case, we targeted the worst point, which was located in the center of that muscle. Okay, now we need to turn him over onto his stomach. Look at that technique on the splenius capitis. Remember, the attachment sites of this muscle are on the lower ligamentum nuchae, C7, T1, T2, T3, and T4. This muscle runs up and attaches onto the superior nuchal line of the occiput and the posterior aspect of the mastoid process. So just let me know the most tender point in this muscle, okay? 1, 2, 3.
1.
Right there?
Yep.
Now what we're going to do is take the head and we're going to extend it and rotate it to the same side. Did that turn it off?
Yep.
And we'll just maintain this position for 90 seconds. This may be easier done on with the client supine, and I can demonstrate that as well. But for the purposes of showing where the points were, I wanted to have the client prone. So remember to slowly move in. This time I used two different movements, extension and rotation. Sometimes you have to combine movement patterns to turn off the tender point. So after the 90-minute time frame, we'll rotate the head back down and let it down into the face cradle. And how is that point now?
A lot looser.
Is it tender at all? No?
No.
Okay. And that's what we want to see, that change. Now what I'm going to do, this is a muscle that we talked about earlier that sometimes has a lot of spasm and fibrotic change. So I'm just going to open this area up with a little bit of just palmar glide stroke. Once I feel like I've got it warmed up pretty good, we can see that the tissue's turning red. Now I'm going to come back in and I'm going to use a deep transverse friction. Doing okay with that?
Yep.
That depth? And I'm going to follow that muscle from its origin down here on the thoracic spinous process, is just lateral to that. And I'm going to trace that muscle upward towards its attachment site. If I get too close to the spine, I'm probably on the trapezius. If I get too far lateral, I'll probably be into the levator scapula. So I want to stay right in the midline. And that's a great way to release the spasm within the splenius capitis and or the fibrotic change that occurs within that muscle from acceleration injuries like whiplash. So that concludes the treatment demonstration using passive positional release for the masseter muscle, the sternocleidomastoid, and the splenius capitis. Now let's take a look at three additional muscles that play critical roles in head and neck pain: the levator scapula, the scalenes, and the temporalis. The videos that you're watching in this presentation are great examples of the videos within my MileFinder application. You can log on to www.milefinder.com for more information. Now let's take a look at the attachment sites for the temporalis muscle. This muscle has an origin on the temporal fossa of the skull. It inserts into the cornoid process of the mandible. Its actions are to elevate the jaw as in chewing gum or chewing food. It's important to note that this muscle is often involved in temporal mandibular disorders and/or tension-type headaches. Now let's take a look at the temporalis muscle on the skeleton. The temporalis muscle has an origin on the temporal fossa located here. This muscle runs down and underneath the zygomatic arch and inserts onto the cornoid process of the mandible. To outline this muscle, we'll come in the front of the ear and around to the back of the ear. This muscle occupies this entire space of the lateral aspect of the cranium. It inserts onto the cornoid process of the mandible. To palpate this muscle, the easiest place to locate it is right in front of the opening of the ear. We use a flat palpation technique to strum across the muscle belly as we trace it up and back behind the ear. We'll continue to outline the muscle, feeling for the muscle fibers as we make our way down to the zygomatic bone and back up to the anterior border of this muscle. Now let's take a look at the attachment sites of the three scalene muscles. The origin of the anterior scalene is the anterior tubercles of C3 through C6. This muscle inserts into the first rib. The origin of the middle scalene is the anterior tubercles of C2 through C7, and it also inserts into the first rib. The posterior scalene originates on the posterior tubercles of C5 through C7. This muscle inserts into the second rib. Collectively, these muscles are responsible for flexion, lateral flexion, opposite side rotation of the head and neck, and they assist in inhalation. The anterior and middle scalene can be involved in thoracic outlet syndrome. All three muscles can be involved in whiplash. Now let's take a look at the scalenes on the skeleton. First, we'll look at the anterior scalenes. The anterior scalenes have attachment sites on the anterior tubercles of the cervical vertebra. C1, C2, it starts at C3. C3, 4, 5, and 6. This muscle runs down and inserts onto the first rib. Now we'll come back up and palpate the attachment sites for the middle scalene. The middle scalene attaches onto the anterior tubercles of C2, 3, 4, 5, 6, and 7. This muscle also inserts onto the first rib. Now we'll palpate or locate the attachment sites for the posterior scalene. The posterior scalene attaches onto the posterior tubercles of C5, 6, and 7. This muscle runs down and inserts into the second rib. To palpate the posterior scalene, we'll use a flat palpation technique to strum across the muscle belly. We'll move anteriorly and strum across the muscle belly of the middle scalene. To help us palpate the anterior scalene, we'll flex the head and neck. Once again, strumming across the muscle belly, and the anterior scalene is located under the SCM. Now let's take a look at the levator scapula attachment sites. It has an origin at the transverse processes of C1 through C4. This muscle inserts into the superior angle of the scapula. The actions of this muscle are elevation and downward rotation of the scapula, bilateral extension of the neck, unilateral rotation to the same side, and lateral flexion. This muscle can be involved in the stiff neck syndrome and also in whiplash. Now let's take a look at the levator scapula on the skeleton. The levator scapula has an origin on the transverse processes of C1, C2, C3, and C4. This muscle runs down and twists around itself and inserts onto the superior angle of the scapula located here. To help us locate this muscle, we'll perform one of its primary actions of lateral flexion against resistance. We can see the muscle belly here of the levator. This is the upper trap, the sternocleidomastoid. To palpate this muscle, we'll use a flat palpation technique and strum across the tendinous attachments on the transverse processes of the cervical vertebra. This muscle runs under the trapezius located here, so we'll have to go a little bit deeper to continue to locate the muscle belly as it inserts upon the superior angle of the scapula. I'm particularly proud of MyoFinder. This is a dynamic musculoskeletal reference with over 100 minutes of instructive HD videos detailing palpatory anatomy, including the attachment sites, muscle and skeletal overlays on high-definition video, narrative instructions, over 78 muscle images, and information on actions, synergist, antagonist, and the muscle's role in common pathologies. When you need muscle information at your fingertips, as we often do in our massage practices, MyoFinder is an invaluable resource. Check out the demo at www.bionexusllc.com. MyoFinder is the ultimate clinical anatomy app. Come along as we take a tour of the unique features of this powerful educational app. Access 7 distinct anatomical regions and 78 individual muscles. Learn the details of each muscle, including attachment sites, actions, synergists, antagonists, and common pathologies. Watch HD videos that superimpose the skeleton and muscle overlays onto live models that enhance the learning of specific palpation techniques. Each of the 7 regions includes video demonstrations of basic stretching and active range of motion. You can test your muscle knowledge through a fun and interactive multi-level quiz while the timer ticks away. This mobile muscle mentor is a must-have for on-the-go learners. To learn more, go to www.myofinder.com.
Thank you, Clint. For more information about Clint's products and his workshops, visit his website. Hi, I'm Ann Williams. I'm ABMP's Director of Education. I'm here in Oklahoma City for Eric Dalton's Myoskeletal Alignment Technique Workshop. I'm going to bring Eric Dalton back to Colorado with me to the ABMP home office. On October 10th, we're going to be offering our ABMP members an exclusive benefit. Eric Dalton is going to share his best techniques and his amazing approach to the body with you in an online streaming event. Join us live online October 10th.